We'll just get started in a minute or two. Hi, everyone. Thanks for joining. We're going to give it another minute and then we'll get started. Okay, hi everybody. Welcome to today's webinar, Optimizing Resources for Sustainable Commodity Supply through Direct Facility Financing, which is the second webinar in the series of 5 hosted by the USAID Integrated Health Program in Nigeria. My name is Stephanie, and I'm the Communications Manager for the USAID Integrated Health Program, and I'll quickly be going through a few housekeeping items before we get started. Next slide. If at any point you're unable to hear one of our speakers, please make sure you've connected your audio using the microphone button on the top right-hand corner of your screen. If you continue to have issues, please add a comment in the chat and one of our staff members will assist you. Registered attendees will be joining the webinars with their cameras and mics off, so please use the chat to introduce yourself, add any comments, or note any technical issues. We will be using the Q&A function for questions, so if at any point you have a question for one of the speakers, please click the Q&A button in the Teams control panel box at the top and enter your question there. Please note that this webinar is being recorded and the recording will be available immediately after the webinar. Next slide. So it's my pleasure to introduce our moderator for today's session, Dr. Al-Rashid Usman, who's the IHP State Director in Sokoto State. Before joining IHP, he was the Country Director for Project Hope USA, overseeing implementation in Nigeria and Sierra Leone. Dr. Al-Rashid is an expert in population health and public policy and trained at the College of Medicine at the University of Lagos. He has an MBA from Abubakar Tafawa Balewa University, Bauchi, and an MPH in epidemiology from Transatlantic University, United Kingdom, an MSc in information technology from National Open University of Nigeria, and a PhD in population health and public policy from Walden University in the United States. Over to you, Al-Rashid.
Thank you, Stephanie. Good afternoon, good morning, ladies and gentlemen. Welcome to our webinar series. Before we start, we'll have our agenda item, and I'm going to introduce our presenters for today, and thereafter we'll take question and answer sessions and discussions after the presentation. Next slide. Ladies and gentlemen, it's my pleasure to introduce our distinguished guest speakers today. We have Dr. Jem Chang Fabong, who works with IHP, Dr. Mohammed Ali Name, former Commissioner of Health in Sokoto State, Onyeka Ojogu works with IHP, Pharmacist Abdulkader Ahmed is the Managing Director of Bauchi State Drug and Medical Supplies Management Agency. And finally, it's Ifeanyi Ume from IHP. Next slide. So without much ado, we'll go into the first presenter. That's going to be taken by Dr. Jem Chang Fabong. Dr. Jem Chang currently works as the Director of Health Financing on the Integrated Health Program funded by USAID in Nigeria. Jem Chung was a former executive secretary of Plateau State Contributory Healthcare Agency, and he will provide a quick opening presentation on health financing for direct facility financing, DFF, in Nigeria. Over to you, Dr. Jem Chung.
Thank you, Al-Rashid, and thank you, distinguished ladies and gentlemen. I'll start by saying Section 11 of the 2014 National Health Act provided the legal framework for the establishment of the Basic Healthcare Provision Fund, which is Nigeria's flagship universal health coverage program. The Act states that nothing less than 1% of the consolidated revenue fund, the annual grants from the federal government, grants from international donor partners, funds from other sources inclusive of the private sector, is to be shared amongst the 36 states and the FCT through the various gateways created by the Act. Now, 10 years after the National Health Act was enacted, less than 2 million people have been covered by the Basic Healthcare Provision Fund. At the last Ministerial Oversight Committee meeting in March of 2024, tens of billions of available government and donor funding was still accumulating unutilized in the Basic Healthcare Provision Fund accounts, despite desperate needs across the country. We have witnessed some changes in the healthcare landscape since the commencement of the Basic Healthcare Provision Fund in 2019, with challenges and lots of lessons learned. In accordance with the guidelines that was created when the BHCPF started in 2018, 50% of the fund is to be used for the provision of basic minimum package of health services to citizens in eligible primary or secondary healthcare facilities through National Health Insurance Authority. The provider payment mechanism for this is capitation and fee for service. 45% of the fund shall be used by the National Primary Healthcare Development Agency as follows. 20% of the fund shall be used to provide essential medicines, vaccines, and consumables. 15% of the fund shall be used for the provision and maintenance of facility equipment and transport for eligible primary healthcare facilities. And 10% of the fund shall be used for the development of human resources for health for primary healthcare through direct facility financing. 5% of the fund shall be used for emergency medical treatment through the fee-for-service provider payment mechanism. However, in 2018, the Act was reviewed, and we have the fourth gateway that was added, which is the NCDC gateway. And the percentages for the funding changed. Formerly, that of NHIA was 50%, and now it's at 48.75%. For the NPHCDA, it remained at 45%. The National Emergency Medical Treatment Centers remain at 5%, but the NCDC, which is the fourth gateway, has 1.25%, and that was solely responsible for public health security. Next slide. Next slide. So the Basic Healthcare Provision Fund in the IHP supported state has a cumulative total of 295,755 beneficiaries as at Q1 FY24 across all the IHP supported states, with all the states exceeding the targets that was created. And of course, with respect to the fund flow, we have a total of 1,023 primary healthcare centers that were empaneled to receive direct facility financing between Q1 of FY21 and Q1 of FY24. And we had a total of 2.6 billion that was sent to these facilities as direct facility financing, with, of course, oversight functions from the Ministerial Oversight Committee to the State Oversight Committees, the Gateway Forum, and then the Facility Governance, which has a Work Development Committee chair as part of it. And then we have civil society organizations will form part of the social accountability framework. Next slide. Yeah, so we have the direct facility financing contributing significantly to drug revolving fund, and one One of it is the contribution to infrastructure, like proper dispensary with tools to keep records and storage facility, and then contribution to the human resources for health through recruiting technical and support staff for facilities, including finance staff to reconcile the drug revolving fund expenditure. Formerly, the DRF was just a facility activity, but the DRF has created platforms to bring community engagements into it. And the capital itself, which is 20% amounting to 300,075 naira of the fund, adding to the capital base of the facility for the drug revolving fund. And the financial management procedure was brought in for proper accountability of the drug revolving fund. Thank you.
Thank you, Dr. Jem Chang. Thanks for that introductory note on the health financing situation in Nigeria and direct facility financing, DFF. Thank you very much. So without much delay, let me welcome our second presenter, Dr. Muhammad Ali Nname. Dr. Nname is a public health physician, a seasoned health administrator and politician with over 20 years working experience in public health practice. He was the pioneer special advisor to the governor of Sokoto State on the contributory health scheme before becoming the Commissioner of Health in 2019. He later became the Commissioner of Finance under the same administration in 2022. Dr. Nname has his MBBS at Usman Danfodio University, Sokoto, master's degree in pharmacology, and master's in health economics. Ladies and gentlemen, please join me in welcoming Dr. Nname to take the next presentation on legislative processes to establish BHCPF and direct facility financing in Sokoto State. Over to you, Dr. Nname.
Thank you so much, Dr. Arashid. Good afternoon and good morning to everybody on this call. In the next 5 minutes, I will just take you through the healthcare legislative landscape in Sokoto State, and also take a brief look at the Basic Healthcare Provision Fund and the direct facility financing implementation challenges and opportunities in Sokoto State. Sokoto State have 23 local government and 244 wards, with 658 primary healthcare and 23 general hospitals and 4 tertiary health institutions. There are just 3 levels of care in the state. That is the primary healthcare, secondary, and tertiary care. Next slide, please. The health outcomes in Sokoto State, particularly the major health indicators, just like the under 5 mortalities in the state, you will see that there are some marginal improvement when you compare it with 2008 to 2018. This is largely due to the poor outcomes are largely due to weak health system, out of stocks of essential medicine, and out of stock of long-acting reversible contraceptive, and poor health infrastructure and low number of healthcare providers in the system. Next slide. In the quest for universal healthcare of Sokoto State, the Sokoto State government, through the Ministry of Health, has tried to establish or enact laws to help it in achieving universal healthcare, largely relying on the Basic Healthcare Provision Fund law of 2014 and the Sokoto State Primary Healthcare Development Agency Act of 2010, and the one that was revised in 2014. Also, the basic minimum package of healthcare services that was established for vulnerable population in the state. Next slide. Yeah, just like the earlier speaker that has given us an overview of the direct facility funding in Nigeria, it's not different from what is happening in Sokoto State with the Basic Healthcare Provision Fund. the 45% that is allocated for the primary healthcare window or gateway, where 20% is being used for its provision of essential drugs, 15% for facility maintenance, and 10% is for capacity development of health workers. Next slide. Overview of Sokoto State Direct Facility Financing and implementation of the Basic Healthcare Provision Funds. The Sokoto State has received 1.142 billion naira from the MPSCDA gateway, and it has disbursed over 550 million naira to 244 primary healthcare facilities in the state. In addition, the impact project of the World Bank also has disbursed monies to the same 244 primary health facilities, like an augmentation to what is already available from the Basic Healthcare Provision Fund. Next slide. There are 4 principles that guide the direct facility financing implementation in the state. Number 1 is largely the autonomy for primary health facilities that receive funds. They have an autonomy to implement or to utilize the resources available to them based on their needs. Then also purchase of health services and facility and financial management skills that has been improved in the primary healthcare facility. And finally, accountability to the community as well as to the health system. Next slide. Legislative and policy support for effective implementation of the direct facility financing in the state. The establishment of the Sokoto State Drugs and Medical Supplies Management Agency is one of the key support ingredient that in the implementation of the direct facility financing, which help in the forecast, procurement, warehouse, and distribution of essential drugs and consumable to those primary health facilities participating in the Basic Healthcare Provision Fund. And also the revision of the Sokoto State Essential Drugs and Medical Consumables, adding additional commodities in the list also was critical in the implementation of direct facility financing. Next slide. Yeah, with collaboration of the USAID Global Health Supply Chain and Procurement and Supply Management Project, it has helped the state in implementing the direct facility financing, especially with regard to the ROG Revolving Fund, training and mentoring of staff of the primary health centers, and also provided technical support for the 244 health facilities in the development of their quarterly business plan in those health facilities. IHP also supported the state with the 40 health facilities, that is primary health centers makeovers, to ensure that these facilities are service ready, especially with regard to warehouses or storage facility for drugs and essential commodities that they receive or purchase directly to those facilities. Next slide, please. So facility and financial management and accountability also is one of the key ingredients for the implementation of the Basic Healthcare Provision Fund in the state, where IHP provided technical support in training of cohort account clerks in those 244 health facilities, as well as training of the chairmen of the ward development committees that are also central in the implementation and community participation of the implementation of the Basic Healthcare Provision Fund and direct facility financing. Next slide. The implementation of the Basic Healthcare Provision Fund and this direct facility financing has impacted positively in some of the areas, especially under 5 children with regard to treatment of childhood diarrhea and pneumonia. When you compare it through the years, especially what happened in quarter 3 and 4 of the 2023. Next slide, please. Success factors and challenges with regard to implementation. Coordination and collaboration is very important and key, where partners and other key actors like the MPSCD and the Sokoto State Primary Healthcare Development Agency, UNICEF, WHO, legislative advocacy and constructive engagement of stakeholders, because some of these laws need to be reviewed from time to time. When you are implementing a new law, you need to review it. So you need legislative advocacy to ensure that everybody is taken on board. Also shared best practices and innovation from other states like Kano and Jiga with regard to the DMA, how they implemented and also recorded a lot of successes in those areas. Challenges, one of the key challenge is the resistance to change by facility actors, key actors, staff from the primary healthcare level, the local government, as well as the various agencies in the state. And also low community oversight. There are not very clear, well-structured oversight at the community level, at the local government level for the health facilities that are receiving these resources. And also the limited field-based monitoring infrastructure and structure that need to be provided. Thank you.
Thank you very much, Dr.
Thank you for listening.
Mohammed. Yeah, thank you. Thank you, Dr. Mohammed Alinami, for that presentation on the legislative processes in Sokoto State for BHCPF, DFF, and DRF. Thank you. Ladies and gentlemen, our next speaker is Onyeka Ojogu. Onyeka works with IHP, and she's going to talk to us on the state of DFF before IHP compared with the current state of the direct facility financing. Onyeka is an advocate of universal health coverage with over 7 years of experience collaborating with government and private sector stakeholders to implement reforms aimed at strengthening the health sector in Nigeria. She is currently the health financing advisor on IHP. Ladies and gentlemen, please join me in welcoming Onyeka Ojogu. Thank you.
Thank you very much, Dr. Rashid, and good afternoon, everyone. So I'll just be providing a brief overview of IHP's experience since providing technical assistance to supported states in the implementation of key health financing reforms. As we're all aware, in Nigeria, the primary healthcare system is faced with challenges like poor infrastructure or limited availability of equipment, drugs and commodities, as well as insufficient funding to the system. All of these challenges. Now, the Basic Healthcare Provision Fund and the State Social Health Insurance Scheme are two health financing reforms that aim to improve the fiscal space for primary healthcare in the country. And IHP provided technical support across our supported states for the implementation of both of these reforms. However, prior to the commencement of technical assistance, we conducted a baseline assessment which helped us to ascertain the state of implementation across our states. And we saw that across each states, there was varied level of readiness for implementation. Some states had their legal frameworks already established. Some had commenced operationalization of the schemes through enrollments and access to services. However, we did see that generally across all states, there was inadequate technical and operational capacity to implement both the financial reforms, and there was also some slow progress in meeting the criteria for BHCPF disbursements as had been set by the national level. Next slide, please. So IHP technical assistance was targeted at addressing the gaps that had been identified from the baseline assessment. For the BHCPF, our focus really was on providing support to ensure that states were able to meet criteria for disbursement. And so we provided technical assistance to establish legal frameworks in states that did not have laws, establishing the state social health insurance agencies and the schemes. We also collaborated with the National Primary Healthcare Development Agency, the state health insurance agencies and primary healthcare boards to conduct conduct training of trainers at state LGA levels, as well as facility assessments. And both of these activities led to the initial approval of PHCs to receive DFF as well as accreditation of PHCs by the NHIA. For the operationalization of the state social health insurance scheme, we provided a wide range of technical assistance, but some key support that was provided included technical guidance for the design of health benefit packages and the revision of essential drug lists across our supported states. And then, of course, working closely with our partner, the GHSCPSM project, we supported legislative processes for the establishment of drug management agencies, building the capacity of the state LGA and facility staff on their operationalization and mentoring facility staff to reinforce learnings from the trainings. Once implementation had commenced, we also realized that we needed to support the states to further build capacity for effective management of funds, as well as ensure accountability and transparency in the utilization of funds. And this was done with support for the implementation of the Facility and Financial Management Toolkit that was developed in collaboration with the NPACDA. Training a pool of assessors who were now tasked with the responsibility of conducting quarterly quality assessments across BHCPF facilities, and then building capacity of the OICs and the LGA level staff to be able to use the results from the quality assessments to develop quality improvement plans and business plans that address specific contextual quality gaps that had been identified from quality assessments. There was also efforts to support states to improve the functionality of their governance frameworks in a bid to ensure accountability in fund utilization. We saw some very interesting results from the technical assistance that were provided to the state. For example, in terms of the PHCs that were approved to receive DFF, this increased from 73% in 2021 to about 100% in 2023. For accredited facilities on the NHIA gateway, we saw an increase in the number of empaneled facilities and primary healthcare facilities from 56% in 2021 to 82% in 2023. And then has the number of facilities that were approved and empaneled progressively increased, the cumulative fund flow from both gateways also increased, reaching about 6 billion by 2023 from about 990 million in 2021. This slide just depicts the progressive increase in cumulative flow funds to we also saw some very interesting improvements in terms of PHC functionality. From the improved capacity to be able to use facility funds, more facilities were able to use resources that were available to them to ensure that their pharmacies were stocked with essential life-saving drugs and consumables, but then also as well as improving infrastructure like fixing of the roofs, recruiting farm techs, and then very interestingly, we saw improvements in the availability of active DRFs at the PHC levels. So for instance, in Kebbi State, the percentage of operational facilities with functional DRFs increased from 16% to about 91% when we conducted our inline assessment. And in Sokoto State, it increased from 7% to 81% at inline assessments. Next slide, please. There were also some good results in terms of drug stockout rates. Using a set of tracer commodities like magnesium sulfate and isoprostol, we saw that the reporting of stockouts of essential life-saving commodities declined between 2021 and 2023 for some of the tracer indicators that were measured. Next slide, please. So a few factors actually contributed to the achievement of our results. The first of which was the continuous capacity building and mentoring that we provided to stakeholders, which which actually facilitated ownership in push for achievement of set objectives and goals. In addition, the availability of the functional DMAs and PHC drug revolving funds also helped ensure that the facilities were stocked with essential medicines that were required for delivery of quality healthcare services. We, however, did encounter challenges in the technical support that we provided to the state. One of the key ones was with the unavailability of a clear framework to track the impact from the fund utilization by the PHCs, as well as the use of paper-based systems and fragmented mechanisms for the use of funds by facilities, which actually created some opportunities for the facility managers to misappropriate the DFF that they were receiving. Next slide, please. Thank you very much.
Thank you, Onyeka Ojogu, for that very, very scintillating presentation on the state of DFF before USAID funded Integrated Health Program and the current status of the DFF. Thank you once again. Ladies and gentlemen, our next speaker is pharmacist Abdulkader Ahmed, who is going to talk to us on operationalizing the DRF through DFF, the lessons from Bauchi State. Abdulkader is currently the current managing director of Bauchi State Drugs and Medical Consumables Management Agency. He has over 15 years experience working in logistics and supply chain management. He has worked with the World Bank assisted program on malaria control booster project in Bauchi State and has facilitated design and development of and implementation of malaria commodity logistics systems in Nigeria. Ladies and gentlemen, join me in welcoming Abdulkader Ahmed to present to us operationalizing DRF to direct facility financings, the lessons learned from Bauchi State. Over.
Good afternoon, and all, and good morning to those in the Americas. Yes, the health system in Bauchi State. Bauchi State is a state in the northeastern part of Nigeria with 20 local governments and 323 political wards. The State Ministry of Health, of course, is the gives guide, policy guide for the implementation of health in the state, particularly with respect to capacity building and capital projects. There are about 8 MDAs, the Hospital Joint Board, Primary Care Development Agency, the Bauchi State Special Social, DMMA, and others. And all these agencies have budget heads from the state as the major source of their operations. There are three levels of care: the primary, secondary, and tertiary. And also there are also private health facilities within the state. Next slide. Next slide. The history of health financing in Bauchi State, of course, as I said earlier, the state government budget is the major source of financing for the health sector in the state. However, some projects towards innovative health financing were implemented, like the Saving 1 Million Lives for Result, Program for Result, the Nigeria State Health Investment Project were all implemented between 2015 to 2021. And now the quadripartite primary healthcare MOU between Bauchi State, USAID, BMGF, Dangote, and UNICEF is also being implemented. Also, the basic healthcare provision fund was implemented in the state from 2021 with the mandate to serve vulnerable populations across the state. And the Budgeted Drugs and Medical Consumables Agency that was established from 2012 was further strengthened with the advent of this innovative financing mechanism, thereby ensuring that commodities are made available to the participating facilities. Next slide. Then why the need for sustainable financing for commodities and for medicines and commodities? Of course, we know sustainable financing is important for the health sector, particularly to ensure that medicines are made available in an affordable manner, and also equipment and infrastructure are equally provided, all with a view to ensuring there's improved quality of service of care at the state level. However, there are some challenges to that. Of course, these challenges include high cost of healthcare services, complicated by price instability due to high inflation. There's weak donor partner coordination at the state level due to poor, and also there's poor engagement with the private sector. There's political will is not very strong, and then there's low allocation of resources, and the low resources allocated sometimes there's misallocation, and then there's pilferages and counterfeit pilferages, and then counterfeit medicines are found to be leaked into public health sector. So all these are challenges that are mitigating the quality of service of care. Next slide. So what was the steps we followed in establishing the DRF in Bauchi State? Of course, there was diagnosis of the whole system, and then facilities that were selected, readiness assessment were conducted to look at their warehousing space, to look at security, to look at manpower. After that, of course, after the assessment, based on the outcome of the assessment, operational guidelines were developed, and over 3,000 facility staff were trained on the operations of the DRF, or how to operationalize DRF in their facilities. After which the central medical stores and the health facilities were capitalized with support from, of course, Global Health Supply Chain Procurement Supply Unit. And then after that, the governance structures were set up. The State DRF Committee through to Health Facility DRF Committee were all set up and strengthened for accountability, and they all include community persons. And then MSVs are conducted monthly by the in-state team, the technical arm of the State DRF Committee, to ensure that the facilities are doing the right thing. Next slide. Okay, briefly, drug revolving fund in Bauchi State led to, initially we had only one store at the state capital, but when we realized that there are a lot of, the distances from some facilities is very far, we established zonal warehouses at the 3 senatorial zones to cut the distance. We also realized that the DRF is not only DMA issue, so the state DRF committee set up focal persons at the State Ministry of Health, the State Primary Care Development Agency, and the Hospital Management Board, so that they will be collecting reports and analyze for decision making. Also, public health commodities and DRF commodities at the facilities are integrated to ensure that we have one reporting. Also, accounts are separate, both at the drug management agency and the facilities. We have to separate drugs account separate from sundry expenditure account. And with that, we realize that with a centralized DRF, it brings about an assured source of quality, affordable commodities to the participating health facilities. Next slide. Okay. Are there similarities between DRF and DFF? Yes, we see that there are some few similarities, particularly they all confer some level of autonomy to the facility, particularly decision on expenditure. And also purchasing of services are largely based on output based in both DFF and DRF. Also, it confers sound financial management in facility because all the facilities has to be trained well on financial management to ensure that there's prudency in expenditure. And also all this ensure that there's accountability, particularly with the inclusion of community-based community members into the running of the DFF and also the running of the DRF. Next slide. Next slide. Okay, DRF in the health facilities. Of course, DRF committee was established in health facilities with the facility in charge as the chairman, and then of course pharmacy in charge as the manager, who is responsible for procuring health commodities for the facilities, be it drugs or laboratory consumables. Community leaders were made part of the DRF committee also, and the DRF committee hold state facility DRF committee hold meeting every month and send their report to the data unit of the state sustainable health supply system committee. All facilities were made to maintain two accounts: DRF account for procurement of drugs and health facility management account for sundry expenditures. Stock and financial control tools are also kept. The 20% from the basic care provision fund add more stock in the DRF facilities, and then the social health insurance gateway, they are registered vulnerables assess their drugs through the DRF. Next slide. Of course, challenges, of course, some of the challenges include initially when we started with a single treasury account, there was decentralized warehousing. Each agency was using their warehouse. There were poor patronage to the DMA, inadequate HR, and all what have you. But having realized that for the single account, we separated the account, as I said earlier, we included community in the DRF committees to improve ownership. Also, we centralized all of our warehousing commodities from donors and from partners now coming into the same warehouse. And then money from DFF and some markup are used to engage more staff to ensure that there's more staff to handle the DRF at the facility. And then, of course, the committees are strengthened to ensure that parallel DRF is mitigated in the facilities. So best practices are the center delivered commodities to the facilities through the last mile delivery, either through 2PL or 3PL. The zonal warehouses that were created was also a best practice for us. There's reconciliation of records at health facility every bi-weekly. And then, of course, the auditing, three-tiered auditing was established: internal auditing, biannual auditing, and then the annually contracted external auditors also. Thank you very much. Thank you. Hello?
Thank you very much, pharmacist. Thank you very much. Appreciate that.
Thank you. You lost
yeah,
me.
thank you for the insightful presentation from Bauchi State. Thank you very much. Ladies and gentlemen, I want to introduce our last speaker for this webinar. He is Ifeanyi Ume. Ifeanyi will be presenting on sustainable financing for ready-to-use therapeutic food and integrating RUTF into the drug revolving fund scheme. Ifeanyi is a public health expert with over 2 decades of experience in designing, managing, and evaluating high-impact, evidence-based, scalable projects addressing reproductive, maternal, newborn, child health, malnutrition, and malaria programs across Nigeria. He works at Palladium. He leads and provides technical guidance and support to the team. And he holds an MBA from the University of Nigeria, Enugu, campus and public and media relations from University of Leicester, UK, and a BSc in microbiology. Ladies and gentlemen, join me to invite Ifeanyi Ume to take the next presentation. Thank you.
Thank you, the moderator, and I want to thank everyone for joining us. I'll be taking us, through how we were able to integrate the RUTF into DRF. So I'll start this conversation with this rhetorical question that why are children dying, especially from preventable diseases, and what can be done to reduce this, child deaths? So having said that, it's no news that any longer that Nigeria faces a growing challenge of providing adequate food for its growing population, which is estimated above 200 million people. So this challenge is further exacerbated by continuous increase in violence and kidnapping across the country. Also, the rising cost of food as a result of the government policy on fuel subsidy removal, as well as the ripple effect of the Russia-Ukrainian crisis, which undermines the economy. Also, the poor knowledge of and practice of infant and young child feeding is also a very big factor, both by the healthcare providers as well as the caregivers, such as exclusive breastfeeding, introduction of complementary feeding after 6 months, in addition to continuous breastfeeding, as well as lack of dietary diversity. As a result, the 2021 report of the Food Consumption and Micronutrient Survey, placed it that over 3.6 million children under 5 in Nigeria suffer from wasting. And if nothing is done, about 20% of these children may die. So the good news is that RUTF, which is ready to use therapeutic food, is a gold standard for treating severely malnourished children. But sustaining this costly therapy has been a huge challenge and a huge barrier to addressing malnutrition in Nigeria. Currently, it's only about 2.8% of malnourished children that have access to this life-saving commodity. Next slide. So what is government doing to address this malnutrition issue in Nigeria? Over the years, both government at the federal and state level have been putting measures to curtail the escalation of malnutrition in children under 5. And some of the efforts put in place include the formation of policies and guidelines, which provide clear and strategic guidelines to reducing the menace. Capacity building for healthcare providers to be able to manage and provide adequate care for the SAM children, and also procurement of RUTF and other life-saving nutrition commodities, mostly through counterpart funding, and also establishments of dedicated CMAN centers where these cases can be managed. And there's also support in this regard from Federal Ministry of Health, supporting at least 3 CMAN centers in each of the states of the Federation, including FCT. And the recent effort to integrate RUTF in the DRF system to ensure all-round stock of their commodity, which I'll be talking extensively as I progress with this experiential learning. And also not forgetting the efforts in enabling environments by the government for local manufacturing of RUTF in Nigeria. Currently, 4 local manufacturers have been certified and are manufacturing. However, with all these efforts, though these efforts are laudable, sustainability is still a challenge, due to high cost of RUT, leading to low access and coverage for these commodities. Now, based on this challenge, and with the quest to addressing the treatment gap in the country, the USAID Nigeria, working through its implementing partners such as IHP, USAID Advancing Nutrition, Breakthrough Action, and Global Health Supply Chain PSM, procured over 60,000 cartons of RUTF as part of its multi-sectoral effort to improve nutrition for healthy and productive population. The intervention is currently being implemented in 3 states, Bauchi, Kebbi, and Sokoto, and this presentation focuses on what is happening in these 3 states. And the coverage of the intervention will provide, commodity and strengthen treatment services, also improve diet and nutrition services. Now, the key intervention that was provided include placing RUTF as a routine service delivery at the PSC by ensuring its availability all year round through the DRF mechanism. So the 3 states have some, mechanisms that are sustainable that they put in place to ensure this is achieved. For instance, the RUTF has been included as in the state essential medicines list in these 3 states, and also included as part of the DRF commodity, which can be procured at the facility and also at the state. And also, IHP was able to provide technical support to the states to be able to include the procurement of RUTF in the 2024 annual operational plan. So, having done that, let's look at individually what each state has done, to sustain these efforts. Let's look at Sokoto State. Through advocacy efforts, the state government was able to approve additional 340 million naira in the 2024 budget for procurement of additional DRF commodities. And there is current efforts to ensure that this fund is released on time. Also, RUTF was included as part of commodities to be tracked by the recently inaugurated State Task Force on Public Health Commodities, which is chaired by the Deputy Governor of the state. And the whole essence is to ensure the security and accountability of the commodity. Also, on the other hand, the health benefit package of the state, the SOCEMA, has been updated, and RUTF and my MMS was included as part of benefit package for treatment of malnourished children, both at the primary and secondary level. For Bauchi State, Bauchi took a different dive. A dedicated model account, RUTF model account, was established, and 5 funding streams was identified for financing this commodity. And the funding streams they identified include 1% contribution from the DRF deferrals and exemption. There's also 5% for nutrition support by Bet Fund Equity. Bet Fund is the state health trust fund agency. And there's also another 5% from the health facility service account, and also nutrition budget line from the state primary healthcare development agency, and also some percentage from rollover fund from the PSCMOU basket funding, which pharmacist Ahmed spoke about, between the state government, Dangote Foundation, UNICEF, and USAID. In addition to the health insurance covered by the Bauchi State Contributory Management Agency. Now, the state also went ahead to set up RUTF, a committee called RUTF DRF Committee. And the membership of this committee is chaired by the Commissioner for Health, and the membership include the MD of the DMMA, also the LMCU state coordinator, the state nutrition officer, and the state DRF focal person, as well as the implementing partners working in the state. The committee scope of work, among other things, include ensuring that the follow up and make sure that the identified funding streams, are remitted, accordingly, and then the account managed. For KB, they've committed to also ensuring that RUTF is part of the management of acute malnutrition, the benefit package of the catchers. So in terms of result that we saw based on this intervention, there was increase in number of CMAN sites where cases are managed, with additional 75 LTP sites set up. So this helped to increase the number of LTP sites where services are made available for clients, thereby reducing the long distances they travel to access treatment. There's also strengthened capacity for over 170 healthcare providers to be able to adequately provide quality MAM services, counseling of caregivers, as well as adequate nutrition and proper documentation of services. And also, I also provided a facility makeover, like my colleague also talked before, to ensure that the facilities are in proper shape to receive these interventions. There was also improvement in service integration at the facilities, including wash, immunization services, nutrition assessments, FP counseling, and other child health services, serving as a one-stop shop so that every child that comes to the facility will be comprehensively assessed and provided the needed services. Also, the DRF system has been fully operationalized in the 3 states, and RUTF and other essential commodities integrated into the scheme. Of course, that the PSN is also equally facilitating an MOU between the state and the local manufacturers so that there will be seamlessness in terms of continuous procurement of the commodity so that it can continue to revolve through the system. Next slide. So in terms of lessons learned, implementing this innovative approach did not come without its challenges and lessons learned. So key among some of the lessons we learned was that some nuances in terms of readiness of DRF for operationalization. So for RUTF to be revolved under the DRF scheme, the system must be operational with clear management structures and quality control mechanism put in place. Also, there should not be, the issue of one cap fits all approach. Each state should design, their sustainability strategies based on existing systems and structures that can leverage upon to finance this intervention. Additionally, the collaboration effort between various MDS, such as the FMOH, DMM, and the rest of them, necessitated leveraging each other's strength and resource base for identifying and activating feasible funding streams for RUTF procurement. Above all, the commitment from the state governments at the highest level is very, very key, to diving into this kind of cost-sensitive initiative, which at the long run will achieve positive impacts and reduction in child morbidity and mortality. Next slide. So for challenges, the biggest bottleneck for managing some cases is the high cost of RUTF, as well as, and as a result of this high cost, it requires huge funding so that this commodity will continue to revolve, knowing fully well that, the end users will receive these commodities free, but there should be a mechanism put in place to ensure that, funds are continuously provided so that commodities will be procured and continue to revolve. And then also there's also a continuous large number of malnourished children in the states. So in terms of mitigations, there's need for government to support local manufacturers of RUTF with low interest loans and waivers. This will reduce production costs and as well, in effect also reduce the costs to the final consumer. Second one is that is also to explore more strategic funding streams for financing RUTF, plus also including it as part of benefit package for the health insurance scheme. And lastly is to improve food security, because we know it's the pain of malnutrition, and also improve dietary diversity, strengthen infant and young child feeding measures, and intensify case identification and referral at the community level. And most important, promotion of the first 1,000 days of life. Thank you everyone for listening.
Thank you very much, Ifeanyi, for taking us through the sustainable financing for ready-to-use therapeutic food and how it's been integrated into the drug revolving funds. Thank you very much. Ladies and gentlemen, I want to thank the first presenter, Dr. Jem Cheng, Dr. Mohamed Ali Nami, Onyeka Ojogu, pharmacist Abdelkader, and Ifeanyi for all their presentation. The next activity we're going to do is take questions and answers and comments, if any, from participants at this webinar. And this will be moderated by Stephanie Mock to look at all the questions on the chat box. And then if people have questions, they can raise up their hands on the team application. So over to Stephanie to moderate the Q&A sessions. Thank you.
Thank you, Dr. Al-Rashid. First up, there's a question from Abul Qadir Ahmed. How did Sokoto include RUTF in the benefit package of their Sochima, considering its cost? Would that go best to Dr. Iname?
Hello, Stephanie. I couldn't get the questions that you asked.
Yeah, okay, no problem. So the question is, how
Yeah.
did Sokoto include RUTF in the benefit package of their Sochima, considering its cost?
Yes, I think considering the cost of the RUTF and the benefit package that the Sokoto state has developed, I think it wasn't much of a problem to include it because this RUTF, it has been shown that in most areas in the primary health facilities are being sold by the health workers. So most of the patients get this through paying out of the pocket to receive these commodities. So by adding it into the benefit package, it makes it easy for those vulnerable groups to be able to access these commodities. And also additional counterpart fund, if you look at what the Sokoto state has also been able to provide additional funding of 300 million plus to support the procurement and the RUTF. So it's not only the financing of the RUTF in the benefit package will not be only sourced from the SOKEMA sources, but other funding from the state government and other partners that also co-contribute to financing the purchase of the RUTF and then distributed or accessed through the health insurance system. That much I can say, but I think the maybe if there is any on this call, if there's anybody from the Sokoto State Contributory Healthcare Management Agency that can add additional information on that. Thank you.
Thank you, Dr. Name. We'll move to the next question from Anne, which is why the choice of emergency contraception as a tracer commodity for family planning and not a long-acting reproductive commodity?
Yeah, that question goes to Onyeka Ojogu.
Thanks, Dr. Rashid. Sorry, Stephanie, I didn't get the question clearly.
That's okay. So the question is why the choice of emergency contraception as a tracer commodity for family planning and not a LARC?
Yeah, so
Sorry,
I think
go
ahead.
So, yeah, Dr. Rashid, I think that question is for the presenter from Bauchi.
Okay.
If I'm correct?
Yeah, so I think it's just an oversight. You used a lot of drugs. There were a lot of drugs used for the tracer drugs in the assessment. However, we just picked the emergency contraception to be able to see how it's doing among the general population. Other long-actings were included, such as Jadel, Implanon, and the other long-acting reversible contraceptives. Thank you.
Thank you for clarifying, Dr. Al-Rashid. So I'll go to the next question. What were the key changes observed in health facility attendance after the implementation of DRF?
Pharmacist Abdul Kader, can you provide insights to that question?
Am I audible? Answer to this is yes. There is increase based on the after
You're very quiet. It's kind of hard to hear you.
All right. Okay. Can you hear me now?
Yes, that's much better.
Okay.
Yep.
Yeah, I said the simple answer is, of course, yes. There's increase in number of visitation to facilities by clients with the advent of the DRF. Based on the NHMI's report we are collecting from the increase in number of clients visiting the implement. So the answer is yes. Was that clear?
Yeah, thank you. Yep. Okay, we can move to the next question. How do we ensure accountability, visibility, and transparency in the DRF and DFF funds as commodities and as use of technology in our health facilities are minimal?
Can we get Dr. Jem Chang to provide response to these questions? How do we ensure accountability? Thank you.
Thank you so much, Stephanie and Al-Rashid. Before answering that question, I saw a question which was related to facility attendance after implementation of DRF. In part of the supportive supervision we had in Sokoto, the facility attendance actually skyrocketed with the implementation of the DRF because medicines were readily available and they were more cheaper to get them in the hospital of sufficient quality as compared to what you find from without. The question of accountability and visibility and transparency with DFF funds. Presently, IHP is supporting the NPHCDA in the development of what we call the direct facility financing mobile verification app, which will help track direct facility financing. Initially, it was paper-based, but we had lots of limitations because of the challenges that health officers in charge has with retirements, and that has affected significantly the payments of DFF on a quarterly basis. But this tool has promised to help the NPHCDA track this funding in accordance with the allocation and due to the percentages, and to as well help them do easy retirements. And at the back end, we have a dashboard that monitors the day of this DFF, whether it's challenged to essential commodities, essential medicines, human resources for health, or the drug revolving fund. We have a back-end dashboard that we could easily monitor this through the direct financial facility financing mobile verification app. And as at the last check, we are done with the deliverable for. Any moment from now, we will start piloting. And the good news is that it can be used both at the NPHCDA, the State Primary Healthcare Board, and it's also facility-based. And we have also created opportunities for placeholders with PHC revitalization processes in for the BHCPF 2.0. Thank you.
Yeah, thanks, Dr. Jem Chang. In addition to what Dr. Jem Chang has just narrated, there are state oversight committee that see the implementation. Then you have the community level where you have the facilities, the WDCs, which are similar to what one of the presenters talked about. And then there is regular audit, quarterly, semi-annual, and annual audit of the states and the facilities to ensure there is accountability and transparency. And lastly is that the expenditures of the facilities are based on approved business and quality improvement plans that are approved by the states before implementation. Thank you for that question.
Go ahead, Abdul Qadir.
Yeah. To add to the two, for particularly for the DRF, commodity accountability and transparency. Most of the warehouses, particularly what we are using M-Supply, and we are already set to deploy M-Supply mobile to our facilities, whereby from my office as the MD, I can view the warehousing of the stores of the facilities. There's the stock available, what they have, what they don't have, and what they are supposed to order. And they can also see the central warehouse and make their order from their facilities. States like some states already, like Yobe and other states, have already deployed other technology-based visibility mechanisms, whereby from the comfort of your office or from the warehouse, you can view what is in the facilities. And the facilities can as well also, in reverse, view what is in the warehouse, so that you can even make your order without coming to the warehouse, From their facilities, they can make their order, and their order can be filled and sent to them. So these are some of the visibility and transparency mechanisms that we are following. Also, from the National Product Supply Chain Program, the NHLMIS that is used to capture public health commodity information from the facilities. Discussions are ongoing on how to onboard essential medicines onto the NHLMIS and also link the NHLMIS to the warehouse management systems that we have, so that there will be visibility and from the top level to the lower level. Thank you.
Thank you, Abdul Qadir. Let's see. So, Jamilu, I can take you off mute if you wanted to ask your question.
Good day, everyone. Good afternoon. Thank you for the presenters. That's a nice presentation from all the presenters, and they really did a lot. My question is, what are those approaches we can use to make sure that our PHC, a sustainable approach we can use to make sure our in case if the partners that has been funding this activity in making sure that our PHC are working functionally or properly, so to a minimum standard. So if these funders are not more there, so we need an approach to make sure this plan in drug, which is the DRF, the rules, the maintenance, all these things can still be in place. So what are those sustainability plans we can you follow to make sure we accomplish it in case if the partner are not there? We need a sustainability plan to keep this. So what are those ways we need, approach we must follow to achieve this? Because it's very important. We need to learn on how to solve our problem within ourselves, because the PHC issues, the partners may be there today and tomorrow they may not be there. So what are those approaches we can use to mitigate such issues in case when it arises? Thank you.
All right, let me give this a shot. Thank you, Jamilu, for that very interesting questions. I think for us, I think maybe I should categorize this into three. First, you talk about infrastructure. Secondly, you talk about adequate human resource for health. And then thirdly, you talk about supplies, that's commodities and consumables. So if you look at infrastructure, one of the biggest challenges we have is that most of the PSCs are not, there are standards, set aside by MPSCDA in terms of the structures and the models of the PSCs. So most of the PSCs does not meet these standards. So first is to make sure that the infrastructure is okay. You go to some PSCs, the roof is leaking, the glasses and louvers are not there, there's no water, the light is not there. Some of them are not even connected to the national grid and so on. So all these things needs to be put in place. Even most of them are not even fenced. Considering the situation we have in Nigeria now with insecurity. And as a result of that, it makes the services provided in these facilities not to be 24-hour service. So you see them most times by 4 o'clock, you don't see anybody at the PSC again. So infrastructure is very key. In terms of human resource, of course, we know what is happening. You get to a PSC, is manned by a CHU or a JCHU, and you have like only 2 or 3 persons working in that PSC. So how can they provide 24/7, services, And even when you have some of these healthcare providers, most of them are not adequately trained and retrained to provide these services. So there's need to train and retrain and also employ more, staff so that they can, continue to work shift in those facilities and provide adequate services. And then lastly, commodities and supplies, very key. There's no intervention without commodities. When you train providers and they're able, for instance, they're able to assess a child that comes to a facility for fever. And then if there's no MRDT, how are they going to know whether the child has malaria or not? And even when there's MRDT and then they assess and the child has malaria, if there's no ACT, work done is 0 because the child needs the medicine so that it can get better from the condition the child is suffering. So I think if we're able to look at these 3, there are so many other things to be done, but if you look at these 3 basic things, infrastructure, human resource and supplies, it will really go a long way. Thank you, Andova.
Thank you very much, Onana. Thank you. I think I wish IHP, which is Integrated Health Program, should at least create a platform, online platform, where we could also deliberate intensively on this, because that's the most important thing we need, so that when the funders are not, there has been an approach which is strategized among the advocate, the CSOs, the CBOs, and the community leaders as well. We should look for a platform, a date and time, and let's find way to make sure that we can mobilize ourselves within each community to bring out solutions, possible solution, doable solution, that we make sure that there is a sustainability way of, even, for instance, there may be someone that maybe a philanthropist within that community if there is no light. So that community leader can have access. When the peer advocate to him, he may tend to fund that issue or solve that problem within that community. So we should just, I think, let's have if there's a IHP can bring a platform online where other communities and NGOs would be able to find a possible solution to make sure we solve this issue. The sustainability is a key. Thank you. Thank you very much, Dr. Kader.
Thank you so much, Jamilo. Onyeka, go ahead. Your hand raised.
Okay, I should add, in addition to what Dr. Ifeanyi said, so on the financing end of things, I think, majority of the funding that's been transitioned to the PHCs, so the PHCs right now is actually government funding. And good enough, these fundings have actually been entrenched in law to make sure that they continue to flow, or that they are continuously released by the government, and they continue to flow to the PHCs. For example, the BHCPF is now a first-time charge at the national budget, and then in state laws we have the equity funds that are available, and also other sources of funding into laws to make sure that the funds continue to flow to the PHCs. But you are right in saying that in addition to this, we also need other sources of financing. Can you hear me? We also need additional sources of financing to the PHCs. So one thing that we did was walk through the quality improvement teams, of which the WDC chairmen are members. So through those quality improvement teams, discussions are held on what the issues are in the facilities and the resources that are required. And then through a gap analysis, they're able to access what's available at the PHC through the funds from the government. And then we now have the community through maybe the village chief or philanthropist coming in to address gaps where they may need more drugs being brought in, or they need additional midwives or nurses. We actually saw community leaders take up that responsibility to address the gaps that we saw to ensure that the PHCs will continue to be functional. But then there are also other avenues of resources or funding that we also try to identify, such as resources from the private sector. We have a lot of private sector stakeholders that are working across various industries in the country. So through engagements with private sector stakeholders, resources can also be generated that can help address gaps that are seen across the PHCs. So these are just some of the avenues that were explored, in addition to the funding coming in from the government, and to make sure that the PHCs are sustainably resourced to be able to address the gaps that that we're seeing at that sector. Thank you very much.
Thanks, Onyeka. I just want to note that we are over time, so if folks have to jump off, that's fine. Thank you so much for joining us, but I think we'll answer a couple more questions before we end the webinar. So I see Jim Chang, you have your hand up. Go ahead.
Yeah, just wanted to add a little on the sustainability approach we need to follow to make PHCs more functioning properly. Part of the take-homes at the last Ministerial Oversight Committee, special emphasis was made with respect to the Nigerian Health Sector Renewal Investment Initiative of the sector-wide approach, and we touched on human resources for health, where a technical working group was commissioned for that purpose, and IHP is at the forefront in the question of training of 120,000 health workers to take care of the challenges we have with the human resources for health at this PHCs. And as well, the federal government of Nigeria understands the problem with donor fatigue, and the sector-wide approach is actually intended to bring about the contributions of private sector and others who want to help in sustaining these primary healthcare centers that have been identified as the bedrock for quality healthcare services.
Thanks so much, Jim Chang.
There is a question in the chat box.
Yes, thanks, Al-Rashid. It says, to the M supply stated, it will definitely increase commodities visibility and also encourage central procurement of commodities by health facilities. But my concern is the lead time. How long will it take for facilities to receive commodities and frequency?
Probably this question is the lead time as it is now, because as I said, it is largely 2PL. Depending on the distance of the facility, it's barely in hours, 24 to 48 hours, and everything is up. Was I audible?
Yes, thank you so much. Jim Chang, is
Yes,
that an old
Yeah.
hand or is that a new hand? Oh, thank you.
It's an old hand. I'll lower it.
Okay.
I dropped a question in the Q&A.
Yes, I see that. So what is happening with NPHCDA Gateway as health facilities in Bauchi State are yet to receive disbursement for the last 3 to 4 quarters.
Jem Chang, do you have a response to that question?
Yeah, thank you. Well, to the best of my knowledge, it's not just Bauchi State that has not received that. It's a nationwide challenge, which was why they at the last Ministerial Oversight Committee meeting that held on the 28th of March 2024, the MOC, which is the Ministerial Oversight Committee, gave approval for the memo to disburse over 25 billion naira of the 2023 BHCPF approved budget to the states across the 4 gateways. So it's not just a problem with Bauchi, it's a general problem. And again, where some states did not receive DFF when other states have received is the question of retirement. And that has been one of the huge challenges with the NPHCDA gateway, with strict definition for the direct facility funding. But that has not been seen as a huge challenge with the NHIA gateway, as we have seen. Thank you.
Thank you so much, Jem Chang. I think that we will wrap it up with that last question. Thank you everyone for joining, and the recording of the webinar will be sent around shortly after. So thank you again for joining, and thanks again to our presenters for such a great presentation.
Thank you. Thank you.